Hi everybody, welcome to our webinar. Just to introduce myself, I'm Katie Roberts. I'm the Primary Care Liaison Manager for CUH. In a moment, I'm going to let our panel introduce themselves. We have allowed you to have your mics and cameras on so that you can ask questions at the end of the presentation. We'd like this to be interactive. But just to let you all know, we are recording the webinar so that we can then upload it onto our GP portal for any of your colleagues that weren't able to make it today. So I will pass you over to our Community Diagnostic Centre team, who will start their presentations. And about 1:30, our virtual ward team will then join us for that part of the webinar.
Thanks, Katie. I'm Anna Marisa Parsi. I'm the project lead for Community Diagnostics, and I'm joined by my colleague Hilary Charlesworth, who's the operation manager. So we've got a few slides which I'm just going to share. So just bear with me a moment. There's always a slight delay. Hopefully you can see those. But yes, as I said, I'm Anna Marisa Parsi. I'm the project lead, and Hilary Charlesworth is the ops manager for ED and with speech community diagnostic centres. So just a brief summary of how we're going to run today's session. I'm going to talk about the National CDC programme, what they are, and Hilary's going to talk about ED and with speech in more detail. So just a bit of background, what is a CDC? So Professor Sir Mike Richards published a report in 2020 looking at diagnostics, recovery and renewal. And one of the key recommendations of this report was the proposed a new diagnostic model whereby patients, communities could access diagnostic testing outside busy acute hospital environments. The primary aims of this was to increase diagnostic capacity, but also to improve productivity and efficiency. It was also a primary aim was to reduce health inequalities by providing access to diagnostic tests out in the community. Particularly, they have focused on areas that are more deprived, where we know people aren't necessarily accessing healthcare when they need to. It's also about improving patient experience. There should be public should be able to access diagnostic tests much earlier. It also supports integrated care as well, and should help improve the health outcomes of the population. So over 160 CDCs are planned across the country. One of the real drivers for this, as part of Mike Richards' report, he looked at how the demand for diagnostics had been rising, particularly even before the pandemic. And in almost all aspects of the different diagnostic modalities, demand had been increasing year on year, and demand was really starting to outstrip capacity. And this was then having an impact on diagnostic waiting times, the cancer diagnosis. So there was a real need. And as you can see here, there are really substantial increases in some really key modalities like CT, MRI, DEXA and PET-CT as well. So this was the real driver behind this. And this is, we've seen an increase in this demand as well in Cambridgeshire and Peterborough. So in terms of where we were before the Community Diagnostic Centre programme started for Cambridgeshire and Peterborough, particularly during the pandemic, we saw a real large increase in our waiting lists for MRI, CT, ultrasound and echocardiography. And although in some of these areas we have started to recover, we do have still some real issues with our waiting list, particularly for non-obstetric ultrasound and echocardiography as well. And this provides an overview last year of where the waiting lists were, and particularly against that key standard of patients receiving the diagnostic test within 6 weeks. We're really struggling again to get patients seen within 6 weeks across the key modalities, MRI, CT and ultrasound. So it's really challenging, and the national target is for 95% of patients to receive their diagnostic test within 6 weeks by the end of March next year. So there's a real pressing need to increase diagnostic capacity. So in terms of community diagnostic centres and what makes up a CDC, the minimum requirements for a standard hub are CT, MRI, ultrasound and X-ray. So there's those key imaging modalities, but also there's physiological measurements as well around cardiac measurements and respiratory as well. And they are also, some of the minimum requirements are also around pathology and providing phlebotomy and point of care testing as well. And what they have suggested is that each system has a central hub which has to provide the minimum diagnostic tests as outlined in this guidance. Though this is an absolute minimum, but there are also others that can do it as well, such as endoscopic diagnostics as well. And then, so each system has a hub, and then there are spokes that are sort of like satellite units that provide outreach to reach those populations as well, out in the more deprived areas as well. So in terms of the east of England, as you can see, there are quite a lot of CDCs being built across the east of England. So the green ones are the hubs, as I outlined before. So we've got a hub in Ely, which we are running, Clacton, West Essex and Bedfordshire. And then the orange ones are the spokes that are linked to these hubs. So there's quite a lot spread out. It's interesting where they are located. We've got quite a few up here with Queen Elizabeth Hospital, Kings Lynn and Wisbech in Peterborough here. And then although this is called Clacton CDC, it's linked to the large hub of Clacton. It is actually based in Newmarket. So I'm going to pass over to Hilary now, who's going to talk in detail about Ely and Wisbech CDCs.
Thanks, Anna Maria, and thank you everyone for attending. It's a fantastic group of people who've joined us, so we really appreciate your time. I think I'd just like to start by saying that this project for CAMHS and Peterborough is evolving, and it's changing all the time in terms of what we're trying to achieve and what we're aspiring to do in the future. So as Anna Maria has told you, we are responsible at CUH for managing the CDCs in Ely and Wisbech. So Ely is based on the Princess of Wales Hospital site. Those of you that know that site, it's directly below the day surgery unit, and that is our main hub. So it will be providing a huge number of different diagnostics. Wisbech is a much smaller unit based at the North Cambs Community Hospital site, and I'll be showing you in a little bit more detail what we'll be providing and how we want to take this forward in the future. Next slide, please. Just to warn you, I am going to flick over quite a few of the slides that I'm presenting because I'm really keen to make sure that we have time for dialogue at the end, because the success of the CDCs is us working together within the system. So we're going to make the slides available to you. So if there's anything you pick up on as I whiz through when I skip slides, then you can please send us messages after the presentation if there's something you want clarity on. So basically, we're using the two community hospital sites, and they are still going to be managed by Cambridgeshire Community Services NHS Trust. So we are leasing those sites. Next slide, please. So we have gone live in Wisbech. We have partially gone live in Ely, and we hope to go fully live in the spring at Ely. So this is from a relatively old slide because we have had quite a few challenges in terms of delivery of some diagnostics, but the way that we have run it for Ely, a lot of our services are actually being managed by professional staff rotating from CUH to cover those lists, and that's how we plan to continue in the future. Wisbech is a little bit more of a conundrum for us because the physical distance between Wisbech and CUH has created its own challenges. So we have employed some staff to do specific delivery of services for Wisbech, and then we are actually having to do some insourcing. So we're working with private companies to deliver certain diagnostics. So we have got mobile CT and MRI vans, which are being provided by a private company at the moment. And then we have just gone live with ultrasound. Unfortunately, echo and ECG are causing us a lot of problems because there is a huge national shortage of echo physiologists to be able to do that. We're trying to liaise to organise a contract to deliver that through an insourcing contract. Respiratory we've gone live with, and we've also gone live with FibroScan for liver pathways. Ely is in 2 stages, so we've had about 25% of the floor space handed over to us, and we are at the moment doing phlebotomy, just started ultrasound and FibroScan. The rest of Ely will be handed over to us in April, and we will be gradually going live with the services. We won't all be doing it in one fell swoop in April. MRI is slightly delayed, and that's hopefully going live in May. Next slide, please, Anna Maria. So this is our floor plan of Wisbech, and just a couple of photographs for you. So both of our CDCs have been designed on the basis of creating as many flexible working spaces as possible. And that's to try and meet the needs of our patient cohorts, in that we probably don't have enough demand in this area to be delivering certain studies every single day. So by creating flexible spaces, it means that we can do different diagnostics on different days. And we have a lovely big store room on the other side of the corridor, so that we are making sure that we've got lovely clinical areas that are clutter-free when we're actually seeing patients in them. So we will be delivering, hopefully, ultrasound and echo. We have the capacity to do phlebotomy, but they do have a service running their outpatients department who currently still have the capacity. So we can future-proof so that we can do phlebotomy there if we need additional space, but it's also being used for a cannulation space for our patients going to CT and MRI. But that's an example at the bottom of one of our multifunctional rooms, which is, you can see, beautifully spacious. All of the rooms are connected to the IT systems at Addenbrooke's, whether it's the picture archiving and communications system, or whether it's the EPR. Next slide, please, Anna Maria. So this is very, very busy slide, is our CDC at Ely. So this is really exciting. So I'm just going to quickly whiz through. So the top half of the plan are all of our multifunctional spaces. So the very top clinics are clinic rooms and what they're calling patient cabins. So patient cabins are basically quite small rooms. However, they're all big enough to be able to put in a 3-section couch, so you know that kind of indicates that they're not too small. They'll all have Epic in there on a PC, so they can be used either as spaces to do diagnostics, or it might be that I'm going to talk about one-stop clinics in a little while, and it might be that they'll be used as a consultation room. The next kind of section are our slightly larger clinic rooms. So we've got 2 what they call treatment rooms, and then 2 what we've randomly called oscopy rooms. So these are significantly bigger. We've got clean and dirty utility available between each pair of rooms. And we've also got one of the oscopy rooms has a co-located disabled toilet, so that we can deliver things like urology examinations from there, and patients will have the privacy to be able to use the facilities without having to go out to into a corridor to empty their bladder. And then the next section down is predominantly the bottom half are the imaging facilities. So within that, we've got a couple of ultrasound rooms, a CT, an MRI, we've got an X-ray room, and then some patient changing cubicles and a subweight. And then in the very far corner on the left-hand side are staff facilities. So we do have facilities for the staff because it's such a big unit. Next slide, please. So these are the slides I'm going to skip over a little bit, but please feel free to have a look at those. And if you have any questions, then please come back to us. One thing I do want to pick up on is just in relation to workforce. So where possible, we have tried to recruit locally for both Wisbech and separately for Ely, so that our support services are provided by as much as possible local people, local populations. So all of our healthcare support workers and our administrators, we've done local recruitment campaigns and have been really successful in recruiting to those posts. We've had slightly more challenges with the healthcare support workers for Ely, but we're working on that to try and fill those posts. So it means that we've also got people living locally to help the economy in the local areas as well. Next slide, please. So that's just a little bit about why the CDCs were happening, and the fact that, you know, it is to address the requirements of the system. So it's all to do with seeing patients that are local, dealing with backlogs. We are expecting anytime soon a new report, which will be the second report from Professor Sir Mike Richards, which will be addressing where we are and what still needs to be done. So we're awaiting that because I believe the first draft is done. So that'll be quite exciting to see what comes out next. Next slide, please. And next slide from there. So just quickly trying to talk about the pathways that we want to try and deliver. So we will be doing a variety of different types of pathways. So next slide, please, Anna Maria. Just going into a little bit more detail. So the diagnostic sets are when we will try to do multiple tests if they're required on the same day, so that patients are only coming to the unit once, and we'll be trying to coordinate their pathways. So the pre-op assessment is quite a good example of that, where the patient will come just on one day. We would do whatever tests are required. Those would go back to the CUH ready, or Ely, wherever the patient's having their surgery, ready for their visit. And liver assessment is another quite good one, where we would do various different tests on the same day as much as possible. Next slide, please. And then the one-stop clinics, this is more aspirational at the moment, but we would hope that down the line we'll be able to deliver some of the one-stop clinics that they are currently doing at CUH, so that patients are not having to go into Cambridge if they live locally. This is going to be a lot more difficult to coordinate, because obviously we need to make sure that the right clinicians are on site, whether that's GP specialists or CUH clinicians, in order to follow through. It's also really important when you're doing the one-stop clinics that you've got your support, often through specialist nurses, to be helping with that communication piece with patients as they're trying to digest a lot of information in a short period of time, which may be quite difficult information. So you know, the specialist nurses are hugely critical to those pathways. Next slide, please. And then this is one that we are really keen to start working on, and where yourselves as primary care providers are hopefully going to be really involved. So these are the enhanced and optimized pathways that we would be trying to work with you, so that I've just used the two examples here, which are ones that have been set up in CUH, so that there is a seamless movement through from you seeing your patients in primary care to when you've actually got definitive diagnosis and hopefully closer to a treatment plan. I come from an imaging background, and I'm very, very aware that we often use general practice as a bit of an administrative role in many respects, where you send a patient for one test, we send it back saying this patient needs something else done. And so there's a lot of toing and froing where you're being asked to send another referral or refer the patient now to an outpatient appointment. We're trying to help with that by doing those initial tests, and if the patient does need another diagnostic test or referral straight into an MDT or a clinic appointment, we will help you to streamline that, to reduce the time from when you're seeing the patient to when we all know what the management of that patient will involve. Next slide, please. So this is just giving you a few ideas of some of the pathways that we hope to be following. We have just put in an application for some funding to develop pathways in our CDC. We're going to be starting with the pathways in Ely, purely because that's where we've got a lot more diagnostic tests that we can deliver. But we would hope that we can extend that out to the rest of the CDCs within the ICS and potentially beyond, because we are doing a lot of work with neighbouring ICSs. So within the application that we've put in, that we're waiting to hear whether we're not successful, we've actually included some requests for funding for both GPs and primary care nurses or primary care practitioners to help us develop these, because it's really critical that we're all working together with secondary care as well to understand what you need and how we can help your patients through some of these navigating our systems. Next slide, please. And that's just giving you an idea of some of the diagnostics that we'll be able to consider. Next slide, please. I'm trying to whiz through so that we have time for questions. So that's just talking a little bit about the long-term planning. So we should be aspiring to providing a 7-day service for all diagnostics, and they should be 12 hours a day. We do anticipate that the remit of the CDCs will change over time. At the moment, screening is not included, but if we have the equipment and the personnel to deliver those, then it'd be lovely to think that we can deliver screening programs and use the opportunistic approach of when patients come to visit us, if they are delayed in their screening, that we could offer those while the patients are in front of us. At the moment, financially, we are relying on central costs to deliver the CDCs, and that will be stopping as of the next financial year, so the end of the 24-25 year. So we do need to make sure that all of these tests economically are viable. So we're doing a lot of work on that now, whilst we've got the central costs in place. And then that's developing the pathways with yourselves. Next slide, please. There, I've whizzed through that really, really fast, because I think it's really important that we understand what questions you have. We would really, really like your input as to how we can help you to deliver services, what your concerns are, and how we can work together in the future. So, Katie, back to you.
Thank you. So there's currently one question in the chat, which is, will there be community transport options for the CDC?
So I anticipate that transport will be dealt with in the same way as we currently do, in that, you know, we have to book transport for the patients to be brought in, but there's no reason why we can't receive patients. So the one caveat to that is we will be able to do patients in wheelchairs. If they are on trolleys, then we wouldn't be able to accommodate those patients, and they would still need to go into the hospitals to be able to be. So we'll have hoists, but we won't have the same level of manual handling equipment that they would at Addenbrooke's.
Thank you. So James, you've got a question?
Hi, so I'm James Booth. I'm a GP. I'm also the medical director of the LMC. I just want to say, I think this looks like a very, very exciting project, and I'm sure that GPs really will want to work, and we want to work representing our GPs around those rapid pathways. I think the one thing I would say, and it's really, really welcome to hear that recognition that general practice is often used in a sort of an administrative role, which is something that we absolutely agree we very much need to move away from. So it's really just to say that we absolutely support that aspiration. I think I'd probably reflect that we shouldn't need a CDC to move away from it. I think that should be something that we're doing anyway, and that we're really happy at the LMC to be liaising with you about some of that pathway development. I think there is a real opportunity here for really streamlining the ways GPs interface with diagnostic services, but it's really, really welcome to hear that you want to have that GP engagement and the system's funding that, and we're really, really keen to support and be part of that engagement.
That's great to hear, James. Thank you very much, because what we will need is to identify individuals, or a couple of individuals for the different pathways. So ideally it would be people with special interest in liver pathways, for instance. So the pathways funding that we've applied for, that we're waiting to hear about, our focus for those are going to be liver pathways and upper GI. So that's so that we can try and start using Cytosponge in the CDCs, because we're very aware of the waiting lists and constraints of endoscopy, but also the fact that there is this alternative diagnostic test that's coming online, which is somewhat more palatable to patients. And with these sorts of pathways, it's thinking about how we can then make sure that the patients are followed up, so that we would try and help take that responsibility for the follow-up. But we're also really conscious with particularly these two pathways. We've had fantastic engagement from the CUH clinical teams for these two pathways, and that's partly why we're keen to move those ones forward initially, because we are looking to think about how we can support the GPs while the patient's in front of us, how we can give them that education and signposting to help them manage their conditions themselves, so that, so this is for your early diagnosis, when it wouldn't be appropriate necessarily for the patients to be referred into secondary care, but it's a case of how we can support you in that way, which is why it's really, really important that we have that input when we're planning these pathways to make sure we're getting it right.
That's really, really helpful. My emails are always open, so please do keep in touch with us.
Brilliant. Thanks, James.
Thank you. Does anybody else have any questions or comments that they want to raise in the last couple of minutes before we move on to virtual wards? Arani?
Hello, sorry, my computer's not, my camera's not working, but I'm Arani, I'm one of the hepatologists at CUH, and I just wanted to reach out and try and introduce myself virtually. But as Hilary was saying, we're trying to develop a liver pathway, so I'd be really keen to collaborate with anyone about what we're trying to devise. One is a liver pathway, but also a direct access to FibroScan pathway for GP, so it's easier to screen for liver disease. And alongside that, developing guidance for primary care in knowing what to do with the results, or who to screen. So primarily we're looking at patients at risk of liver disease, so our type 2 diabetics, the obese patients, those who we know are drinking alcohol in harmful amounts, and then what pathways we can devise to get them seen and assessed. And I'd be really keen to, if anyone wanted to reach out or get in contact to collaborate on these pathways, because I think it's important that we know what's manageable for primary care to recognise and also implement some educational things alongside it. So that's my little spiel.
Thank you. Are there any other questions or comments before we move on? No? Well, thank you very much, Anna and Hilary. We will now move on to virtual wards, and I will let Ian introduce himself, and at the end of his presentation, feel free to ask any questions there as well. Thank you.
And thank you very much for the introduction. Good afternoon, my name is Ian, or Ian Goodhart. I do anaesthetics and intensive care as my day job, but I also do, I'm the clinical director for virtual wards at CUH, and I also oversee what we do with virtual wards across Cambridge and Peterborough. My brief is to talk to you about what we do at CUH. Now, my wife is a GP, orchard surgeon in Melbourne, and she tells me frequently that I have not engaged with GPs and I've not told you what we do. So my aim today is to try and make up for that and show you roughly what we do, but probably most importantly, leave some time for questions. Gemma Check, who's the matron in charge of virtual wards, is going to join shortly, but I'm speaking first because otherwise I won't get rid in edgeways. So I'm going to share my screen and give you some little slides. You've all got your cameras off, which is fine, but if you want to say anything, either do put your hand up or just shout out. Heather, have you got your hand up? Okay. So virtual wards mean different things in different parts of the country, and it's important to know what it is that we're trying to achieve in different places. I'm mindful also that virtual wards are not geographic restricted, so some of you on the edge of the patch will have patients who will be looked after by virtual wards which are not CUH and not Cambridge and Peterborough ICS, and this again can cause problems because some of them, quite frankly, are sort of expanded community services who might then just put more pressure on you as GPs, and others might be seeking to try and do the opposite and try and support the patients and try and improve the quality and safety of the discharge and actually support you in primary care and the community teams as well as offloading the pressure in the hospital. The problem is that virtual wards means turning upside down what we do in the hospital, because a lot of the hospital clinicians, even though you might think we want to just throw them out all the time, are actually really anxious about sending their patients out into the community, and they find the virtual wards really uncomfortable. But why is it worth doing it? Now, I know the government talks about money saving, decompressing the acute trust, enabling patient flow, but actually the main reason we're doing it is because of the patient experience. This is some feedback from one of our patients who had been in the virtual ward, and it's not feedback which is very comfortable to read, because really it describes this poor patient having a pretty rubbish experience in hospital. And we all know that that patient is not alone in having that experience. But you can see that that brief period of time at home in the virtual ward while they were unwell between their surgeries enabled them to have that strength to be able to have the psychological reserve to be able to get through the next stage in their treatment. And what we find is that our patients like virtual ward care. They don't want to be trapped in hospital. They don't want to have that loss of dignity and privacy. They want to be at home with people that they know in an environment where they're comfortable, that they're familiar with, that they can mobilize in more safely. A little journey to the fridge and back, a little journey to the TV back, to the toilet and back, little steps in a safe, familiar environment is much easier than having your one walk with the assistance of the physiotherapist down the ward. There's an awful lot that we can do through virtual wards to improve the patient experience and help them to recover well. And we've been really clear at CUH that we want to get that right. Now, a lot of the work that we've been doing has been with early supported discharge and step down patients. We haven't had an awful lot of admission avoidance, and we certainly haven't had any direct admissions from new GPs into the community. And the reason for that is because we haven't felt confident that we've got a robust enough service to be able to support those admissions directly in from the community. But this is something which we need to start doing in the next 12 months. So what have we got here at CUH? Well, we've got consultant oversight. So all of our patients remain under the care of CUH. So if you have a patient, one of your patients is under our virtual ward, they shouldn't necessarily be coming to you. They should be our responsibility. We should be dealing with their medicines. We will courier out medicines if we change them. We will organise the blood tests. We will send them home with remote monitoring if it's appropriate. We're available 24 hours a day, 7 days a week. The patients have a phone number. They ring it 01223 806 806. It will be answered by one of our nurses. We collect call data metrics on the response times, drop calls, missed calls, and we make sure that we are responsive to those calls. Other virtual wards elsewhere in the country are not 24/7. They operate between 8 and 6. And quite frankly, I don't know what they think happens in the middle of the night for their patients. But we know what happens, which is that the patients deteriorate, they panic, they'll phone 111, they'll come in via A&E in the ambulance, which isn't good for the patient. And I don't believe is the best way forwards. So we've been really clear that we want a service which is open to all of our patients in the trust, that's inclusive, that uses technology and able to free the patients and safety net them, provides individualized patient-centric care. We can do home care as required with home visits from the nurses. Our consultants have been doing home visits as well. We were supposed to only have 45 patients, but the demand's been so high that at the moment we've got around 72 patients per day, and we've got nearly 32 different hospital specialties. We opened in November 2022. The occupancy graph shows you how we've grown over that time. Most of our patients are quite elderly. We have a huge range of specialties, and our ethnicity demographics are the same as they are for the rest of the hospital. You may have come across a lot of negative stuff in the press. If you possibly have any time, you might have come across this article about how virtual wards supposedly cost twice as much as inpatient care. This rather inflammatory article was based upon research which was done 2 years ago in a virtual ward which was costed for having about 120 patients, but actually only had 40 patients in it. And so the metrics really don't work. But I'm going to explain to you how they work, how they calculate it, and why you get all this sort of spurious stuff about the cost of it, and how we get judged. We get judged on bed day savings, and the maths is completely rubbish in my opinion. Last year, there were over 2,000 patients admitted through CUH with a diagnosis of pneumonia. Some of these are kids, some of them are elderly, some of them have got hemato-oncology problems, some of them have had surgery, some of them have got bog standard community-acquired pneumonia. What the government does is they say, right, well, let's take those patients between a 5-year age band, okay, and this is the patients between 65 and 69, and that's their distribution of length of stay. So get rid of all the other patients, just look at that 5-year age band, and in there we've got 5 patients who came into the virtual ward. What's the average length of stay for a patient with pneumonia in that age band? Well, it's 8.9 days. So then they say, right, well, 1 patient stayed 8 days, so we'll give you 1 bed day saving. 2 stayed 4 days, so you get 4 bed day savings. 1 stayed 3 days, you get 5 bed day savings. So that gives you on average maybe about 4. That's that patient who stayed 21 days. We don't really care whether or not they stayed in the virtual ward for 5 days, 10 days, whether they needed to. We're only going to allow you to have 1 bed day saving. So you end up with this really silly maths, and it's really, really unhelpful, because what we actually want to be doing is delivering care which benefits our patients. But it can also benefit the organisation. The reason being that if we're saving 4 bed days, then we've got space where we can put in other patients and we can do elective procedures, which helps us to get the waiting list down, which helps us to give your patients the treatments that they need. But you'll have noticed that isn't really having the effect yet. And the reason for that is we haven't really grown to a big enough size. Although we've got 72 patients in our virtual ward at the moment at any one time, we've only had under 3% of the patients with pneumonia in the virtual ward. In my mind, every patient who's in our hospital should potentially be able to go home a little bit earlier with the virtual ward. Not to dump them on you in primary care, not to say, oh, GP to follow up, organise bloods, check the chest x-ray, but to actually support that discharge. Because if you've got a patient who's in hospital for 5 to 10 days, the normal course of events is they begin to get mobilising. They can see that, oh, maybe I could go home, waiting for the TTOs, waiting for the doctors to feel confident in discharging them. And then they go home and then they suddenly feel a bit lost and stuck. Okay, what do I do now? Because they're not actually well yet. They're not back to normal. They're not ready to go back to work often or carry on with their normal lives. They're still a little bit unwell and they can feel quite isolated. With virtual wards, we can send them home that bit earlier, but we can also safety net them and support them when they get home, thereby improving the quality of care, making it safer, and reducing some of the burden on you guys in primary care. But we haven't done enough yet with engaging with the community teams. And that's something we really, really need to work on. In order to do that, we need to increase in scale, we need to do more listening, we need to be able to work out which patients can benefit and how we're going to make safe, robust pathways for them. These are ileostomy patients. The red line indicates when they were on oxygen devices. At the moment, we can't do short-term oxygen. The blue line is how long they were in hospital. And you can see the vast number of these patients were in hospital for about 4 or 5 days. They didn't need to be. And so we've created a pathway, very clear what we do, how we manage them, and then those patients go home earlier. There's lots of stuff that we can do in the community that we've been doing for years in the chronic setting, but we need to think about what we can do in the more acute setting. And one of the key things, my things, is observation of the patient at risk of deterioration. And this is why I want to move to a point that you guys can refer patients in directly to the virtual ward. So if you've got a patient who you're uncertain about, you think they're at risk of deteriorating, maybe some monitoring, maybe some oversight out of hours over the weekend, you would ordinarily think, actually, you know what, the only way I can safety net this is to send this patient to ED. Not a great experience for the patient. They don't necessarily need to then be admitted, but there's a high risk they would do. We could pop them into the virtual ward. We can use remote monitoring to get continuous heart rate, continuous blood pressure, saturations, continuous temperature. We can monitor these patients almost as intensively as I can with my HDU patients, but with them being at home, being able to mobilise. So with the virtual hospital setting, with what we're trying to do here at CUH, it's looking at trying to increase our capability as a team, increase what we can do in reaching out into the community, enabling us to look at what are the limitations. So we can't do oxygen at the moment, we can't do IV fluids at the moment. So that would stop us sending a patient to the virtual ward. But if the patient doesn't have those needs, maybe the following day, maybe they can come into the virtual ward. Maybe we can continue with this monitoring. Maybe we can safety net them and make sure that it's safe. So to do this, we're trying to make virtual wards as part of standard care. This is a pathway that we have for aortic dissection. Patients have been staying in hospital for 4 or 5 weeks with aortic dissection. But actually all we're doing is checking their blood pressure once every 3 days or 2 or 3 days and monitoring that. We can do that with that patient at home where they can mobilise, they can be free from the risk of hospital-acquired infections. We can be really, really clear in our pathways about who's responsible for what, who in our teams is doing what, making sure that that patient's safety netted, making sure they can get hold of us at any time. Our patients are acutely unwell, which is different to some of the other virtual wards. This is a patient who was going to self-discharge. We said, no, please don't self-discharge. Yeah. How about coming into the virtual ward instead? So they were new diagnosed fast AF, and we were titrating them, bringing their medications to try and keep them safe, but safety netting them in the virtual ward. We've got lots of different community-facing teams within our ICS, within our community, and I think that there's an awful lot that we could be doing to work more effectively for the benefit of the patients. And I see that the virtual wards, if we run them properly, can function as a coordination, as a glue that can stick these together for the most unwell patients in order to try and prevent them from having to come to hospital, but make sure that we're looking after them properly with clinical oversight, with the same access to investigation tests and medical support as they would if they were inpatients. And I'm really keen to make sure that we deliver a quality service which is good for our patients and good for the whole healthcare system in our region. It's not simply a case of decompressing the hospital and sending our patients out into the community for you guys to have to pick up the pieces because you're already working, as my wife reminds me regularly, very, very hard to do that, and that I don't want to design something which adds to that burden. That was a whistle-stop tour of roughly what we do. We have a call centre set up which is manned by nurses. We have 4 nurses working at any one time during the day. They've got a consultant with them as well who's either ED, acute care or care of the elderly's background. We have patchwork consultants who are joining our team, and we've got a dedicated cardiologist as well supporting the care of these patients. We've got a pharmacy team. All medications are dealt with by that pharmacy team. When a patient's transferred from the inpatient environment to the virtual ward environment, we generate a TCO and discharge summary, and that discharge summary at the top states that the patient's in the virtual ward, that there's no responsibility for you in the community to have to deal with the issues in that discharge summary. The reason we give you that though is so that if the patient does turn up, you've got a fighting chance in understanding what's going on. When the patient is then discharged from the virtual ward for real, then you'll be sent another discharge summary. There's a frustration here because I feel that that's duplicating some of your administrative and charging work. But we've felt that was the safest way in making sure that you know what's happening with the patient, you know what we've done with medication changes, and you know what the follow-up arrangements are. One of the things which I'm looking at in the future is also about potentially having some GPs working on the virtual ward alongside our consultants. And I think that there's an opportunity there, and I think that would help massively with our integration community team working. Anybody wants to chip in and say anything, have any whinges, complaints, moans, questions, suggestions, please do. If you put your cameras on, then it's easier because then I can see who you are.
Okay, so Zoe's first.
Hello, Zoe.
Hi, Ian. Thank you for that. So I'm a GP at St George's Medical Centre in Littleport. I have had very few patients go via the virtual ward so far. I've only had one patient that I can think of who has, and it worked well. I had reason to call the virtual ward about the patient, and I was able to get hold of someone and discuss the issue. I was just wondering more about how this looks practically. So if we assess a patient, we think they would be suitable for the virtual ward, do we then call someone? Does a nurse come out and give monitoring from CUH? What happens there? How do you link in with the JET team? And what about carers and things like that? So just practically how it looks from our side and from the patient.
This is the big thing which we haven't yet solved, which is that community integration piece. And I've been desperately keen to do it. I'm sort of pushing that we really need this. So the reason we've not done it yet is we didn't have regular consultant staffing. For virtual ward, we were reliant upon locums, and I didn't feel that we could offer a service unless I could guarantee that that would be staffed. So we've now got much better consultant staffing numbers. And so that's the next stage. The other reason is my acute medical colleague said there's no need for this because we've already got GP liaison, we've already got SDEC, we've already got Clinic 5. I do believe there is a need for this. I do believe that you've got patients out there who we could benefit by providing the continuous monitoring. For care home patients who we could avoid that trip into ED for their investigations. So there are a number of things that I want to do to make this happen, and that does mean having better links with JET, with radar, having a direct admission pathway, and this is something which we're working on. So we haven't got it yet, but when we do, I want to make sure that I've got some enthusiastic GPs who are willing to contribute to building that pathway, so we design something which is fit for purpose. So if any of you are willing to do that, if you could drop me a line, that'd be really, really good. So at the moment it doesn't happen. So
regarding that, Ian, I presume you already have a GP working on the pathways, though.
So no, is the honest answer.
Okay.
Which is about right, isn't it? So I do periodically email James and say this is what we're doing, but otherwise no, the pathways haven't done because they've been very CUH centric, and I think that's limiting our opportunity and limiting what we can do to benefit you. This morning I had a meeting with Eileen Nixon and the community pneumonia respiratory team about what we need to do to try and get them supporting, because there's 16 of them out there across the patch who have got a caseload of 400 patients, they've got experience, and again we need to be engaging with them. So no, we don't have any GPs actively attending our meetings and contributing, although there is an open invitation to the LMC to do that. So if you're interested in joining in or just being involved, or occasionally looking at what we've done, saying that's rubbish, that's good, that would be brilliant.
Thank you. So Vanessa?
We've had a few patients, so I'm GP at Bourne Surgery, we've had a few patients on the virtual ward. Just some early sort of feedback about how it's worked. We need to find a better way of identifying who's on the virtual ward from a primary care. Obviously the TTO is really clear. The problem is patients forget that they were told just to ring that number. They ring our surgery, they end up on my triage list. It might be a few hours before I get round to calling them, at which case I go, oh, you're under the virtual ward, you could have rung them hours ago. So we're been trying to speak to the IT team about if there's a way we can launch a protocol, so actually when they ring in something flashes up so that our receptionist or whoever's dealing with them knows. But that would be an IT solution that would make this a bit smoother from our end. I don't know what that solution is, I'm not very IT good, but it's already been a problem at our end from that point of view.
There are a couple of things, and the problem is the Epic System 1 and MetaVision problem, and then even within System 1 you've got the GPs and you've got the community thing. You're Meridian PCN, aren't you?
Yeah.
And there is an option for GPs to be able to have access to Epic, but that doesn't help because you don't have the time to log into Epic. You don't even have you wouldn't have the time to even see, if you didn't have the discharge summary to log on, it just add too much to your burden. So we need to have somewhere in which we're regularly messaging and updating. And I have been struggling with that. There is a solution which we're discussing with the PCN and with Emma and Matt, who lead digital for and Razal, the PCN, and it's not for PCN, for the ICS, about having a shared platform where there's an IT solution and they think that they can take the information from Epic and push it out to System 1 in order for you to get an alert with that. Would it help? Would you need it if it was in System 1 so it flagged up? Would that help?
It would be great if when you open that patient's record that, we have various other things that will flash up, needs a double appointment, needs a translator. There is a way of doing it, but actually if it could flash up this patient's currently under CUH ward, it just means that at that first point of contact with primary care, they can be signposted back and reminded they've got that phone number 24/7 and to get on the phone.
That's all you need, isn't it?
Yeah, exactly.
I'll ask around to see how we can do that.
Yeah. And my other was on a very simple practical point. So we had someone who was under the virtual ward who needed just their routine repeat medication. I know you said you would send out, prescriptions that are required. Does that include their ongoing
should be,
medications?
yes.
Because otherwise there's a safety risk from our point of view. I know we've had a discharge summary, but yeah.
The normal theory is that normally patients should be sent home with 14 days of their standard medication that they should be continuing and the new medications. What we do with the virtual ward is that a lot of them are going home with 28 days in order to cover the sort of anticipated virtual ward time and the time after that. And then our pharmacy team will make modifications to the medications going forwards. We've had a problem with resource for the pharmacy team to be able to do dosset boxes. So we've not been able to have many patients on those because that's a problem.
Okay, no, that's brilliant. Just from our PCN pharmacy team, just to be clear that they shouldn't be touching reconciling medicines or be involved at all until they're discharged.
Yeah. So from the end of April, we'll be hosting the Papworth patients in our virtual ward. That's the plan. That pharmacy arrangement works for the CUH and will work for the Papworth patients, but other virtual wards elsewhere in the country who may be neighbouring you will work very differently. Some of them simply write it on FP10 and fax it to the pharmacies. If it's a CUH virtual ward patient, then we should be taking responsibility for that. If you have problems with that, again, just let me know. You can email me directly. There's only one of me on the NHS mail, or you can give us a call. We want to know if things aren't right because we want to get them right.
Awesome, thank you.
Mark.
Hi, I'm Mark Brooks, a GP at Nuffield Road in North Cambridge. It's just to flag, join the dots about something. So we have a lot of care home patients. Quite interested in the whole care home idea about kind of you doing this in care homes, virtual wards in care homes. But there's a bit of work that's starting off at high referring care homes where there's going to be a wraparound service or something. So it's just really to flag with you that there is a bit of work around high referring care homes going on already.
Yeah, this is one of the challenges. There's lots of different things going on around the system, and we need to try and make sure that it's linked up and the wraparound care to see how we're providing that. Is that work, do you know who's doing that? Is that on your PCN or is that part of the grantor?
I think it's with grantor. It's part. I think it's an ICS wide thing, but I think it's a pilot partly with grantor. Yeah.
So yes, we've been looking at working with grantor to work out how we can use that as a stepping stone, because grantor isn't 24/7 and they don't have any monitoring. And I believe that there's a variable experience in GPs referring into that service as to whether they found those capacity at the time that they made referrals. Anything else?
Thank you. There's a question in the chat. It says, do you have a pharmacist that's able to visit patients and reconcile medications?
Now, I know that CUH pharmacy generally, one of the deputy chief pharmacists was working on a project where they had a consultant pharmacist who was potentially going to be doing that for other patients and frailty patient groups. Within the virtual ward, the pharmacy team haven't done home visits themselves yet because they've been working more remotely with the patients. But yes, we have a pharmacist, a prescribing pharmacist who does the medication reviews and medicines reconciliations on all of our patients in the virtual ward. Does that any half answer the question? I feel like I've given a politician answer. So they're not proactively just doing specific medication reviews. My understanding is that within your PCNs that some of those pharmacy teams are doing that sort of work, but that would be separate to the virtual ward. Okay. Anything else? Thank you very much for your time and your questions. As I said, we're really, really keen to make sure we get things right. If you've got issues, if you've got suggestions for what we can do to improve, it's great. If any of you possibly have the time to be either just linked in via correspondence or to contribute to any of our meetings or pathway designs, particularly when we're looking at what we're doing with care homes, what we're doing with frailty, then that would be really, really good. At the risk of offending our colleagues in grantor, there seems to be often a reflex to go to them because they're one big unified PCN, which is obviously quite effective for testing things out. But I want to make sure that all the GPs in the area actually feel able to contribute to this and able to have a voice rather than just have things distorted by one group, which may not be reflective of the experience of everybody, or may not have, or you guys may not have the resource or the benefit of scale. So again, anyone to be involved, please do let us know. We're really, really keen to engage with you. Good, thank you.
Thank you everyone for coming. We appreciate your time and I hope you found this useful. We're very keen to do more events like this throughout the year. So if you have any ideas about what you'd like to hear more about, then please drop us an email on our GP queries email address that you all use for contacting us, and I will put it in the chat to make sure it's there as well. But thank you all for your time and I hope you have a good rest of the day.
Thank you.